One issue is there's the huge political sentiment about Obamacare and is this socialized medicine. Okay, so that's something that has to be overcome. The second part is one that is, this year was simply time. By the time they got the information, and by the time they invested into getting the health insurance exchange, which had 3 years worth of political consensus building around it, it was able to pass. There had been no time to do the consensus building around this. And so essentially, and because everyone thought this was a done deal, and then the Supreme Court said, guess what, you have a choice. And then everybody had to figure out, okay, what does this mean in terms of how we, and the states were still suing, and even with the health insurance exchange, almost every person who voted for the health insurance exchange started out saying, I hate Obamacare, but.
That's why it took 12 hours.
And so you still have that kind of, and so, and you look about how do you do affordable care. If you say, do we want to cover everybody, that's a basic question. And there are different ways to do it. One way is a single payer plan with a low administrative cost. That would truly be like the Canadian or the British model or the Canadian model. Nobody wanted to do that.
Or the veterans.
Or the other model you have is this combination that was put together. Some other foreign countries have models where you still have private healthcare providers, you have private insurance companies that are not-for-profit that do nothing but process claims, and the government set upon rates. But in many of those other countries, the cost of becoming a physician and going through residency is not put on the shoulders of the student, but the government covers that cost as part of the public good. And when you ask a student to incur $200,000 worth of debt, most students decide you can make a lot more as an orthopedic surgeon than you can as a family physician. So you have a lot of that complex. So essentially over 10 years, if you looked at what we did, cost savings, you could still save $85 million and cover everybody by just covering what you want to do. Now that does not count, this thing does not count the $9 billion of revenue that would come into the state for the claims that would be paid for people receiving health care services. So this savings of $84 million is the cost offset, but doesn't count the revenue that would come in. So the Hospital Association took a look at this. Said, what would that do? And asked an economist at the University of Idaho, Steve Peterson, did an economic analysis. So if you put $9 billion into the Idaho economy, what does that do? And that goes into every community in the state. It doesn't just go to Boise or Pocatello. It'll go to Arco. It'll go to St. Mary's. It'll go to Bonners Ferry. It'll go to Cuna. It goes everywhere. So the analysis is this would create 16,000 jobs and generate over $61 million in sales, property, and income tax over a 10-year period. How would this state react if Boeing announced that it wanted to build a plant with 2,000 people anywhere in this state? We would jump all over ourselves to try to figure out how that makes that happen. We were talking about wanting to work with the Department of Defense to become a drone test site. We've talked about doing, looking at how we handle nuclear waste at the INL. This makes both of those pale in comparison. Okay? Yes?
How do you solve the access problem when physicians aren't taking Medicaid paid, patients?
One of the issues that we've talked about is access. Massachusetts ran into that access problem. Part of it is how you design the care system, and so if you ask the physician to do all the work, it's tougher, but if you have a payment system where a nurse could answer some of the questions and you don't lose it. The university here generally has a pretty strong physician assistant and nurse practitioner program. Those folks can do a lot of primary care in coordination with physicians. And so if you just count on physicians and specialty physicians, you got a problem. If you think about a teamwork of care, there's ways to get at that and get it done.
Couldn't they have done more community health centers in the state and covered more people in high population?
Yeah, the community health centers, actually the part of the Affordable Care Act was $10 billion to fund growth of community health centers. That's a whole other part of the act. Some of that's been moving forward, but 2 years ago when the Congress was cutting budgets, they took $600 million out of that. But there is some new money, so health centers have been expanding. So there's one in Lewiston now. In Pocatello, Health West joined up with a residency. There's been one in Moscow is just about ready to start. So they are growing. So that's another option. So there are options because it really is this multifaceted process. So $61 million. We do know, for example, there's a workforce shortage. Everyone tells us the county monies have run their course. And the hospitals have this other deal that they did. To get the Affordable Care Act passed, the hospitals historically have been getting this payment from Medicaid called disproportionate share. So if a hospital serves a disproportionate share of low-income and Medicaid patients, they got a little extra boost. Well, in part of the deal to get the bill passed, the hospital said, well, geez, if everybody's covered, then I guess we'll give up the disproportionate share payment because everybody's covered. So that was part of the bargain. Well, when the Supreme Court said, guess what, Medicaid is optional, they didn't throw out that little piece about disproportionate share. So the hospitals are on the hook for, in this state, to lose $500 million over the next 10 years in disproportionate share payments that they thought they didn't have to worry about losing because the Medicaid expansion was going to happen. So the expansion is not happening, so they're sitting here thinking, oh my gosh, if the state does nothing, boom, this is where we're at. The other piece of this, so let me just throw one more thing out because, well, for me, the biggest part of all of this is how we take care of each other. What does this do? This is economically beneficial to the state of Idaho, to the communities, to the healthcare providers in general, but most importantly, it's of value to our fellow citizens who live in this state who go day by day not knowing if they can get the care they need, living sick, putting care off, waiting too late. How do we treat those folks? And this is really what fundamentally as a country, how do we care for each other? This is at this point, yeah.
And that's very consistent with the Idaho Constitution, the health and welfare clause.
Yeah, so it's in our Constitution. But really this is what it's about. How do we care for each other? Because in the meantime, if we cover everyone and people are healthier, you have less absenteeism, you have higher productivity, you have better health status, there's less stress on the family. We know that 50% of the bankruptcies are health-related right now. You can look at the whole picture and it just makes a huge difference. Kids are healthier. Sick kids don't do well in school. If you do good preventive care, you can reduce. We do need to look at how we deal with obesity, diabetes, hypertension, mental illness in this. We don't have the systems to take care of it. So what was the impact of the Idaho legislature not acting in March? I can understand the time frame and the dynamics. Understanding and accepting are two different things. So by not acting, the Idaho legislature has basically given away the first 6 months of 2014. So if you think about the impact of giving away the first 6 months of 2014, one could estimate that there's about, well, it's not an estimation, there will be about $40 million of cost in terms of the medical indigency and county catastrophic funds that the state will incur that would have been covered otherwise. There's about $20 to $23 million worth of tax revenue that won't come in because you won't have the bigger employment. And there's about $400 million of revenue to healthcare providers that won't be seen. So that was the economic impact of the timing and the decision. So even if the 2014 legislature takes a look at it and makes a decision, it may be August, September, October of 2014 before you kick in. And so that 100% funding doesn't slide with you. The 100% funding is for calendar year 14, calendar year 15, calendar year 16. So every part of 14 that you lose is just money that you lose.
So realistically, it'd be 2015 before this takes effect then?
They could actually probably get it going in the last quarter of 2014. When could it get going? Probably September, October 2014 is probably the earliest it could happen.
Is there any chance of a special session?
No.
Is there a chance for a special session?
With an election year coming up?
I think a number of folks have talked about a special session, but you know, special sessions usually last for a day and usually are called because there's been a whole lot of work done and everybody's pretty much agreed to it, and so people come to town and the session lasts a couple hours. This is going to take a lot of meetings like this to get a sense of people that what has to be done and when it can do. So as much as I would like to see a special session to kickstart it, the reality is it's going to take there's a lot of people in the Idaho legislature that are still trying to absorb what they did with the health insurance exchange. And folks were just not ready to take this on, and the special session has already been talked about and folks have said wait. The other part of it is health and welfare is going to have to get a fairly solid assurance from the feds that this insurance model would probably work, because that's part of the sales job. So there's just too many moving parts, to be honest.
Are there others like you that are going out to the general public in public forums and just explaining what you just explained, the financial impact to this state?
There's a group called the Right Medicine for Idaho that's mostly in the Treasure Valley that's starting to do this kind of thing. But this will happen over the course of this year. Somebody back there had a question.
Have you extrapolated out the human element here between now and 18 months till if this actually came into being, how many people would die?
Oh, a few hundred. That's a piece of the argument, because there are someone, and Tom was right, there's somewhere around over the course of a year 500 people that will most likely die because of inadequate health care. Is he okay with it? Okay. So that's it's a very difficult, the problem, what I've run into sometimes is that works real well, and then other times people say, don't infuse emotion into the argument.
They should be related to some of those 500 people.
Yes, they should.
Neighbors or their children.
So, yeah. Anyway, that's my presentation. Are there questions? I think that's it. There you go. Yes. No.
What about those of us who have insurance? And it looks like the insurance that we have is going to cost twice as much as going on an insurance exchange.
If the exchange only works for people below the age 65.
Okay.
I was trying to figure out a nice way to say that, but the exchange.